Coming to the next set of origin charts. Coming to the evaluation of liver function test. So when you are suspecting a liver disease and the liver tests are abnormal, if it is acute, less than 6 months, or if it is chronic, more than 6 months. So if the hepatic ALT is raised and mixed ALT and alkaline phosphatase is raised, then diagnostic evaluation should be done. IgM anti-HAV, HBsAg, IgM anti-HBc, anti-HCV, ANA, SMA, monospot heterophile test, ceruloplasmin for Wilson's disease, alcohol history and drug history. Liver biopsy in acute liver disease reserved in patients whom the diagnosis remains unclear despite medical evaluation. If it is a cholestatic pattern, that there is increase in alkaline phosphatase, increase in GGT, and increase in ALT, then diagnostic evaluation by AMA, drug history, ultrasound MRI, MRCP or ERCP is to be done. Now, if it is chronic, that if it is greater than 6 months, and if ALT is again, if it's a hepatic or the mixed pattern, then you will evaluate for HBsAg, anti-HCV, iron saturation or ferritin, ceruloplasmin, alpha-1 antitrypsin deficiency, ANA-SMA, ultrasound, and alcohol history. Liver biopsy in chronic liver disease often valuable for diagnosis as well as staging and grading of the liver disease. If it is a cholestatic pattern, like if it is increase in alkaline phosphatase, increased GGT and increased ALT, then the diagnostic evaluation will ask for drug history, antimicrobial antibody, P-ANTA, ultrasound, and MRCP and ERCP. Now basically, when a patient comes to you, you'll have to find out with a normal liver test, you'll have to find out whether it is acute and chronic. And after that, you have to see the liver function test and see whether it is a hepatic or mixed pattern or whether that it is a cholestatic pattern. Based on that, you will have to basically evaluate. Cholestatic pattern basically will more in favor of drug history or any kind of surgical obstructive causes. Hepatic, more of hepatic causes. What are the causes of cirrhosis? What are the causes of hepatitis? Serological test, ferritin and ceruloplasmin, like Wilson's disease, hemochromatosis. All these things, hepatocellular carcinoma or any other autoimmune hepatitis, you need to rule out. So accordingly, we'll do the evaluation. Evaluation of chronically abnormal liver test. If isolated evaluation of bilirubin, elevation of bilirubin, then fractionated hemoglobin, if it is greater than direct hemoglobin or if it is less than 15% direct. If it is more than 15% direct, it is Dubin-Johnson's or Otter syndrome. If that is less than 15% direct or it is more of indirect hemoglobin, we'll evaluate for hemolysis. So if hemolysis, if workup is negative, then it is Gilbert syndrome. And if it is workup is positive, then it is hemolytic anemia or any kind of hemolysis. If the liver tests are chronically abnormal, you will review the drug list. You will do hepatitis C antibody, hepatitis B surface pattern, iron profile, TIBC and ferritin for hemochromatosis, ANA, SPP, ceruloplasmin, and ultrasound to look for fatty liver. If workup is negative, then rule out celiac disease. Consider other non-hepatic cause. If workup is negative, then you will consider liver biopsy. If the liver function test is a cholestatic pattern, you have to review drugs and ultrasound. Ducts not dilated, check AMA and ERCP and liver biopsy. If the ducts are dilated, CT, MRI, ERCP and AMA is negative. If EMA is negative, you can also do a liver biopsy. If there is also isolated elevation of alkaline phosphatase, then what you will do is you will fractionate the alkaline phosphatase or check GGT or 5-nucleotidase to assess the origin of alkaline phosphatase. If alkaline phosphatase is of bone origin, then you will do bone evaluation. If alkaline phosphatase is of liver origin, then ultrasound, review drug list, check AMA. You either do the ducts are dilated and do an MRCP, or if the ducts are not dilated or AMA is positive, do a liver biopsy. This is a bit complicated, but if you understand the concepts, then it is better. You have to find if it, first of all, for bilirubin, you'll have to find out whether it is more of direct or indirect. If it is direct and if the workup for hemolysis is positive, then it is hemolytic anemia. If the workup for hemolysis is negative, then you will make a diagnosis of exclusion as Gilbert syndrome. But if it is more of direct hyperbilirubinemia and if the workup goes in favor of Dubin-Johnson's or Rotor syndrome, if it is more of cholestatic pattern, then you will have to do a review ultrasound to see if the ducts are dilated or it's not dilated. If it's dilated, it is more of an obstructive cause. For that, you will do a CT, MRCP or ERCP. If the ducts are not dilated, then you will check antimicrobial antibody. If it's negative, again you will do a liver biopsy. If it is isolated elevation of alkaline phosphatase, you'll have to find out the source of alkaline phosphatase, whether it is bone, whether it's ovaries, or whether it's the liver. So if it's in bone origin, you will go in terms of bone evaluation. If 5-nucleotide or GGT is, if the GGT is positive, then you will again do an ultrasound or review or check antimicrobial antibody and ultimately do a liver biopsy. So this Crigler-Najjar syndrome type 1 and type 2 and Gilbert syndrome. So Crigler-Najjar total serum bilirubin is usually 18 to 45, usually greater than 20. It is usually less than 20 in case of type 2. And typically it is less than 4 in Gilbert syndrome. Routine liver tests are normal. No response to phenobarbital. Connecticut is usual. And hepatic histology is normal. In case of Crigler-Najjar type 2, very important is the decreases bilirubin for greater than 25% in case of response to phenobarbital. And it decreases bilirubin to normal in case of Gilbert syndrome. Normally, connectors is absent. And hepatic histology is usually normal, increased lipofuscin pigment in some. Bile characteristics, pale or colorless, greater than 90% is unconjugated. Largest fraction is monoconjugated. And the bile is pigmented. In case of Gilbert syndrome, it is normal dark color, mainly deconjugates, but monoconjugates is increased. Bilirubin UDP glucorosyl transferase activity typically absent. It is markedly reduced in case of type 2, and it is reduced typically 10 to 33% of normal. It is autosomal recessive inheritance, predominantly recessive in case of type 2, and it is recessive in case of type 3, but since mutation of 7 of 8 dominant. High-risk population in whom HCV infection screening is recommended is persons born between 45 to 1965, persons who have ever used injection drugs, persons with HIV infection, hemophiliacs treated with either clotting factor concentrates prior to 1987, persons who have ever undergone long-term hemodialysis, persons with unexplained elevation of aminotransferase levels, transfusion of transplant recipients prior to July 1992, recipients of blood organs from a donor found to be positive for hepatitis C, children born to women with hepatitis C, healthcare, public safety, and emergency medical personnel following needle injury or mucosal exposure to HCV contaminated blood, sexual partners of persons with hepatitis C infection. Risk factors for alcoholic liver disease: quantity in men is 40 to 80 gram of ethanol per day. Induces fatty liver. 160 gram per day for 10 to 20 years causes hepatitis or cirrhosis. Only 15% of alcoholic develop alcoholic liver disease. Women exhibit increased susceptibility to alcoholic liver disease at amounts of greater than 20 gram per day. 2 drinks per day is probably safe. Hepatitis C. HCV infection concurrent with alcoholic liver disease is associated with younger age of severity, more advanced histology, and decreased survival. Genetics. Pathogen-like phospholipase domain containing protein, that is PNPLA3, have been associated with alcoholic cirrhosis. Fatty liver alcoholic injury does not require malnutrition, but obesity and non-alcoholic fatty liver disease are risk factors. Patients should receive vigorous attention to nutritional support. This is a very important table again. If HbS-Ag is positive, anti-HbS is negative, IgM anti-HbC positive, HbE-Ag positive, then it is acute hepatitis high infectivity. Again, if HbE-Ag is positive and anti-HbC is IgG, then it is chronic hepatitis high infectivity. If HbE-Ag is negative and anti-Hb is positive and IgG antibody, then it is late acute or chronic hepatitis B low infectivity. HbE-Ag negative pre-mutant hepatitis B. If HbS-Ag is positive, anti-HbS is positive, and anti-HbC is positive, but then HbS-Ag of one subtype and heterotrophic anti-HbS is common. Process of seroconversion from HbS-Ag to anti-HbS, that is rare. If anti-HbC is IgM and HbS-Ag and anti-HbS is negative, but HbAg and anti-HB is positive or negative, then it is acute hepatitis B and anti-HbC, or that is the window period. If the same with IgG and anti-HbAg is negative, HbS-Ag and anti-HbS-Ag is negative, then it is low level hepatitis B carrier. So this is a carrier state. And if anti-HbS is positive and IgG antibody anti-HbC, then it is recovery from hepatitis B. How to differentiate? If it is an immunization, then all will be negative except for anti-HbS, which will be positive. So it is immunization with HbS-Ag after vaccination and hepatitis B in the remote past. So anti-HbS will be positive only in case of vaccination, rest will be negative. Development of ascites and cirrhosis. There will be cirrhosis, then there will be portal hypertension. Splanchnic vasodilatation, there will be increased splanchnic pressure, lymph formation and formation of ascites. If it is arterial underfilling, activation of vasoconstrictors and natriuretic factors, there will be sodium retention and there will be ultimately plasma volume expansion leading to formation of ascites. There will be alcoholic hepatitis, alcohol abstinence, nutritional support. If the MELD score is more than 21 or discriminant function is more than 32 with the absence of any comorbidities, no GI bleeding, renal failure or pancreatitis, you start prednisolone 32-1 or prednisone 40 mg per oral daily for 4 weeks. Now coming to the very important chart again, classification of portal hypertension, that is prehepatic, hepatic and posthepatic. Prehepatic will be portal below before the portal liver basically. So portal vein, that is pre-portal vein thrombosis, splenic vein thrombosis and massive splenomegaly, that is Banti syndrome. Hepatic, it is pre-sinusoidal, that is schistosomiasis, congenital hepatic fibrosis. Sinusoidal will be cirrhosis, alcoholic hepatitis. Post-sinusoidal, which will be hepatic sinusoidal obstruction, that is veno-occlusive syndrome. Post-hepatic is beyond the liver if there is any kind of obstruction, that is Budd-Chiari, inferior vena cava, Webb's. Cardiac causes like restrictive cardiomyopathy, constrictive pericarditis, or severe congestive cardiac failure. So treatment of refractory ascites is large volume paracentesis with albumin, dietary sodium restriction plus diuretics, ascites reaccumulation. Then consider tips, continue LVP with albumin as needed and consider liver transplantation. The definitive treatment is liver transplantation. Tips, and this albumin plus large volume paracentesis is used as bridge therapy until a donor is arranged.